In the next section, we will look at the esophagus as a whole. We will discuss the anatomy of the esophagus and diseases associated with esophageal dysmotility, as well as congenital disorders of the esophagus. Welcome to the GI Physiology module. In section 3, we will be talking about the esophagus and disorders of esophageal anatomy. First of all, some basics. The upper third of the esophagus has skeletal muscle, which has voluntary activity, and the bottom 2/3 consists of smooth muscle, which has involuntary activity. The upper esophageal sphincter is made up of 4 muscles. The innervation is via the dorsal motor nucleus of cranial nerve 10. The superior and middle pharyngeal constrictors, which consist of 90% of the upper esophageal sphincter, a few fibers from the lower pharyngeal constrictor, and a few fibers from the stylopharyngeal muscle, which is innervated by cranial nerve 9. The gag reflex is controlled by cranial nerves 9 and 10. Lesions of the nucleus ambiguus result in the loss of the gag reflex, but peristalsis is still present. Patients with the gag reflex will need to be fed by an NG tube or a PEG tube, as they will be unable to protect their airway. This manifests itself clinically when patients have had strokes or other disorders affecting the nucleus ambiguus. Lesions of the dorsal motor nucleus affecting cranial nerve 10 will have a gag but not peristalsis. These patients can still be fed because of the intrinsic property which is present to smooth muscles of peristalsis. This results in waves of secondary peristalsis propelling food down the esophagus into the stomach. These patients, however, will need to eat smaller meals as there is no primary peristalsis occurring in these patients. The lower esophageal sphincter normally remains in a state of tonic constriction. This prevents reflux between meals, and acetylcholine increases the resting tone. Release of nitrous oxide and vasoactive intestinal peptide from interneurons innervated by other vagal fibers causes it to relax. Peristaltic swallowing wave produces a receptor relaxation, i.e. when the lower esophageal sphincter senses the wave coming down, it begins to relax, and it therefore allows the bolus of food to enter the stomach. In this section, we will discuss problems with lower esophageal sphincter relaxation later on. There are numerous disorders of esophageal anatomy which manifest itself especially in the pediatric population. The first one is esophageal atresia. This is when there's a blind pouch at the end of the esophagus, and it's a congenital disorder. Children present with vomiting with the first feed. This can't be emphasized enough because clinically this is often missed. If children begin to have problems right from the outset, consider a problem such as esophageal atresia. There are different types of esophageal atresia, namely types A, B, C, and D. In type A, there is a connection between the esophagus and the trachea, with no connection between the proximal esophagus and the distal esophagus. In type B, the proximal and distal parts of the esophagus connect to the trachea. In type C, there is just a blind ending for the proximal esophagus, and the distal esophagus is connected to the trachea. And in type D, or so-called H type of esophageal atresia, there is the esophagus remains patent, but there is a fissure between the trachea and the esophagus, resulting in food contents entering the trachea, going into the lungs, and resulting in choking. In esophageal atresia, a chest X-ray should be carried out because patients will often have a big gastric bubble on the chest X-ray. With the H-type tracheoesophageal fistula, patients present with coughing and choking with each feed. The milk will drip into the trachea and will have milk coming out of the mouth. Choanal atresia occurs when a membrane that connects to the pharynx does not dissolve. The choanale is represents the space between the nostrils and the pharynx. When this space is not present, when children feed, they turn blue, and as they're not getting any oxygen, and turn pink when they cry, as this is a way of increasing the amount of oxygen that they're taking in. The Zenker's diverticulum is a diverticulum or an outpouching that occurs above the upper esophageal sphincter. When it occurs there, this is a congenital problem and results in the coughing up of undigested food. As food particles have often been sitting there in this little bag or outpouching for some time, patients will often present to the doctor complaining of halitosis. Barrett's esophagus or metaplasia represents squamous cells in the lower third of the esophagus that become tall columnar cells. There is a 10% risk of adenocarcinoma in patients because of constant reflux of acid into the lower third of the esophagus. This results in dysplasia, and subsequently 10% of patients can develop adenocarcinoma. Endoscopically, what's seen are tongues of Barrett's esophagus or tongues of metaplasia, where these abnormal cells are present, and they look very different to the rest of the esophagus as shown in this photograph. Mauri-Weiss syndrome is a superficial tear in the esophagus from retching or vomiting. This is seen numerous times every Friday and Saturday night in the emergency room when patients who've been out drinking or been vomiting for any reason develop a superficial tear in the esophagus from the forces associated with retching. This will often present with the vomiting up of bright red blood. It's often seen in alcoholics and in patients who make themselves vomit, such as bulimics. If a perforation occurs secondary to extreme vomiting, this then is called Boerhaave syndrome. Boerhaave syndrome presents by sudden onset chest pain after vomiting, and 90% of perforations occur on the left side of the esophagus. They'll develop a left-sided pneumothorax and will often develop a left-sided pleural effusion, with deviation of the trachea to the right and deviation of esophagus to the left. Boerhaave syndrome is a very serious clinical condition and often requires surgery. Hammond's sign is when subcutaneous emphysema is seen in the presence of Boerhaave syndrome because air is present in the mediastinum when it should not be there. Esophageal achalasia is a disorder of the lower two-thirds of the esophagus. This is when there's a deficiency in the myenteric plexus and deficient release of nitrous oxide and vasoactive intestinal peptide. This results in the absence of peristalsis, failure of the lower esophageal sphincter to relax. What then happens is that food is unable to enter the stomach because the lower esophageal sphincter acts as a gatekeeper to the stomach. Food accumulates in the esophagus, and as it begins to accumulate, dysphagia occurs for both solids and liquids. Patients will complain about feeling full early or complain about vomiting with solid or liquid food. Other symptoms as esophageal dilatation occurs is chest pain, regurgitation, and a nocturnal cough as they're lying back, and so food can trickle back up from the lower part of the esophagus back into the mouth. The onset is often insidious, and progression occurs over many months or years, and patients can often present in their 40s and 50s. The condition, if you ever become a gastroenterologist, that will haunt you or you will love, depending on how you want to earn your money, is gastroesophageal reflux disease, otherwise known as GERD. It's popularly known as heartburn and represents the reflux of gastric and or duodenal contents into the esophagus. The esophageal pH drops as low as 2 when gastric acid contents are regurgitated back up into the esophagus, and reflux can cause epigastric pain, especially after a meal. The pain may radiate to the chest or the arms, and therefore reflux disease is a great mimicker of cardiac chest pain. It's common in pregnant or obese persons. It's common in pregnant women because they have their lower esophageal sphincter is more relaxed than in the average individual, and in obese persons, the lower esophageal sphincter is often more patent. Lying down after a meal contributes to reflux, and this is why patients who present with reflux are told to take smaller meals, to sleep with numerous pillows so that reflux does not occur, and the third thing that they're often told is to lose weight. Complications of reflux disease include esophageal ulcer formation due to gastric acid being present in the esophagus where it shouldn't be, as well as Barrett's metaplasia, as cells which are present in the esophagus change to try and cope with the gastric acid content that they're being exposed to in the esophagus. The main causes of GERD are a weak esophageal sphincter, a hiatal hernia, which I will discuss shortly, pregnancy and obesity, as we've already mentioned. There are also other medications such as morphine, calcium channel blockers, and anticholinergic agents, which contribute to esophageal reflux by loosening the lower esophageal sphincter. Alcohol and smoking are important contributors to GERD because they again can relax the lower esophageal sphincter and can make increase gastric acid secretion. Nasogastric intubation for longer than 4 days is often a cause of GERD as well, because they keep the lower esophageal sphincter patent as the NG tube goes through the nose into the stomach and has to traverse the lower esophageal sphincter. As I mentioned earlier, hiatal hernias are an important cause of gastric esophageal reflux disease. There are different types of hiatal hernias. The first type is the sliding hiatal hernia, where with a sliding hiatal hernia, the gastroesophageal junction and a portion of the stomach are above the diaphragm. This is a very common hernia which is seen in about 40% of the population. The important thing to remember is that most members of the population are asymptomatic with this type of hernia. With a paraesophageal hiatal hernia, a portion of the stomach only is adjacent to the esophagus. These are generally asymptomatic, but as you can see in this diagram, if the narrowing that the stomach is going through is too small, it can result in incarceration of the stomach and strangulation, and these patients can often present with severe pain. A mixed hernia is when a sliding hiatal hernia is present, but there is also a portion of the stomach which is adjacent to the esophagus, and so can also result in incarceration. There are different causes of hiatal hernia. The most important are aging, as the obesity, pregnancy, trauma, and esophageal carcinomas. That concludes our section looking at the esophagus. The take-home points from this section are understanding the fact that the esophagus has both striated and smooth muscle, knowing how esophageal atresia can present, as well as knowing the two different types of hiatal hernia, namely sliding hiatal hernia and paraesophageal hiatal hernia. In the last section, we discussed the anatomy of the esophagus as well as disorders of the esophagus. Commonly tested questions include esophageal atresia as well as gastroesophageal reflux disease.